Thank you. Thank you.
So we have, first of all, a Q&A session.
Can everyone hear me okay? I'm a bit short. Is the mic in the right place? No. Feels like karaoke night.
And what would be your karaoke song?
I don't know. Something with Mark. We'd do a double act.
Yeah. So question one is Emma White in the front row. And I'll come over with the roving mic, Emma. So question one for Professor Gordon.
Thank you. First question is, where do you see the most promising breakthroughs in lymphedema research happening in the next 5 to 10 years?
Big question to start with. Can I just say
a nice, easy one to start?
Thank you. Can I just say, firstly, it's a pleasure to be here. It's an absolute honour to be invited, and thank you. Closer to the mic, I can do that. Is that better? Yeah. Bit more. Then I'm blocking your screen, Matt, for video purposes.
Extendable gadget.
Better? Yeah. Wonderful. So firstly, thank you very much for the invitation. And thank you to everyone here for the fundraising that you're doing for lymphedema research. It's hugely appreciated by us at St George's and everyone in the lymphedema community. So thank you. And secondly, Matt, you asked me to come and speak, and I willingly went, yes, absolutely, and asked you how long I've got for my PowerPoint presentation. And you went, no, you can't do PowerPoint presentation. I like to hide behind my slides. I can talk for hours with pictures of my patients, but this for me is actually quite challenging to just be interrogated, but I will do my best. And Emma, your question is fantastic and challenging for the first one, so thank you. So the question was, what do we see promising breakthroughs in the next 5 to 10 years? I think we can break it down into different subsections because there's a lot of research going on. At St George's, primarily the research that we've been doing for the last 3-4 decades is on genetics. And I think we are making new gene discoveries all the time because primary lymphedema, which is relatively rare in the field of lymphedema, that's the type of lymphedema that children are born with a weakness of their lymph system, even though the swelling isn't always there at birth, it can develop later. That genetic problem is there at birth. But there's many different types, at least 200, I think. It's not just one disease. And 20 years ago, we knew of 1 or 2 genes that could cause it. Now on our gene panel, we've got 41 genes. So we're making all these discoveries. So we're understanding more and more about what causes lymphedema in these children and young people. And whilst at the moment we don't have a gene therapy that can treat these patients differently, I think it's so important to understand the mechanisms of their lymphedema so that one day we can have tailored treatment for the different types of genetic lymphedema. And I also think by learning about the different types of primary lymphedema, the genes involved in regulating someone's lymphatic system, why it works and doesn't work, by learning more about that, we're going to unlock a lot of mystery surrounding secondary lymphedema. So it is worth looking at the genetics, I think, for the benefit of all lymphedema patients. So to answer your question, what's going to be exciting in the next 5 to 10 years for primary lymphedema, it's going to be understanding the genetics that hopefully will give us more targeted treatment for patients with primary lymphedema and maybe secondary. But it's not just genetic research that's happening. There's a lot of research happening on imaging of the lymphatic system. For, as long as we can remember, in medicine, the lymph system has been ignored. And I think that's because it's a see-through system, so it doesn't show up on an X-ray or a CT scan. So doctors and surgeons have, they're included in doctors, I suppose, have ignored it. And when someone's having an operation, the surgeons can't see the lymph system because it's see-through, so it's cut through, it's traumatized readily. So we need to have better ways of imaging the lymph system to understand what's gone wrong in disease, what happens in primary lymphedema, the different subtypes, and secondary lymphedema. So we need to have better imaging techniques to look at the lymph system, understand what's not working properly, and only then can we have better treatments. We want to have something more than compression garments and Velcro wraps, thank you very much. But until we know what's going on, we can't tailor treatment. So I think that's going to be important as well. And I think also drug therapies will be something that we can look back on in 10 years' time and go, yeah, okay, we've made a difference there. Thank you.
Thank you. Very thorough answer. And I'm just going to walk this way in preparation for question 3. My question, the lymphedema community appears to be largely represented by women. And we know the male voice is just as important, don't we? How many patients are treated each year at St George's, roughly? And what is the approximate percentage split between men and donkeys?
Okay, so at St George's Hospital, bearing in mind we're one of the national clinics, so one of the biggest clinics in the UK, I think at last count we saw about 18,000 patients in the last year. Some of them were for their, they were seen twice in a year for their follow-ups. So in terms of new patients through the door, we're getting more than 2,000 referrals a year. So more and more people with lymphedema are at least being referred for treatment for help, which is encouraging. I'd say the split, though, between male to female is probably 80% female, 20% male. And I think, that's a complex one to unpick why that might be. Perhaps men aren't so good at seeking help. Please go see the doctors about anything that's worrying you, please. But what I think is encouraging is when I look at the younger patients coming through, I think we are seeing, a much more even split between boys and girls coming through. So I think education is really helping. The healthcare professionals, the paediatricians and the GPs realising there are clinics that can help these young people with lymphedema. So I think we're getting an equal balance coming through from the younger generation.
Which is good, because the younger generations are having to talk about their feelings and talk about their condition. But us oldies, we tend to sit on things, and I think the goal if there is anything to stand for, it's really to bring us better out and speak, and the film crew, no doubt, they spoke to you, with our opportunity to raise awareness and to share our experience as well. But thank you very much indeed for that. Question 3, we have Sue.
Actually, I'm Sue for the silence. I know that we just talked about genetics and treatment for primary, but my question was, did you share any recent developments or progress being made towards potentially cure?
Wouldn't that be wonderful one day to have a cure for lymphedema? Yes. I hope in my lifetime we may have a cure. Perhaps I'm being a little optimistic, but I'm confident in my lifetime, my working career anyway, we will have treatments for lymphedema. I think it's about finding disease modifying treatments at the moment rather than cures. For several years now, there have been research studies looking at ways to improve the lymphatic system's function. That can again be split into primary lymphodemas and secondary lymphodemas. There have been some work in mouse models, and then more recently in humans, looking at the use of VEGF-C, vascular endothelial growth factor receptor C, to try and get the lymph system to work better by introducing that. At the moment, the results aren't so positive, but at least people are working on it and they're going back to the drawing board, and hopefully that will lead to something in the future. We've got Stan Roxon's excellent work looking at the anti-inflammatory drugs, bistatin. That's really exciting, because many of us will appreciate that inflammation plays a key role in lymphedema. You can see the lymphedema swelling up when there's an inflammatory problem going on. So I think if we can target the inflammatory pathways with these medicines, that's something that's going to be really helpful. What's also exciting is using disease-modifying drugs. So drugs that are already out there that we're repurposing. We haven't really been able to use that in secondary lymphodemas yet, but in some of our specific primary lymphedema patients, we now have some drug treatments that we can use to help them. These drugs, unfortunately, aren't going to help for the majority of patients with primary lymphedema, but for some with specific gene mistakes that we can identify and test. For example, someone with Noonan syndrome that has a mistake in the rasopathy gene pathway. If they've got progressive lymphatic problems and they've got fluid filling up around the heart and the lung and they're getting very poorly, we can actually use medicines that are used for melanoma cancer treatment, lung cancer treatment. They target that pathway and can significantly improve the quality of life and potentially save lives. And same for other conditions with mistakes in the PIK3CA gene that causes a condition called Klippel-Trenaunay syndrome, where one limb is big, swollen from lymphedema, but it's also big because of increased growth of muscle and bone, and it's progressively growing. These medicines target that pathway and can slow things down and actually reverse the changes. So whilst it's not curative for them, it's certainly, improving quality of life and potentially saving lives. So exciting things are happening.
Thank you very much indeed. The next question is from Carol.
Hi, I have neck lymphedema following radiotherapy cancer treatment. And I know how to manage the external lymphedema, the massage, but I have a lot of internal lymphedema, which causes me difficulty with swallowing. And I wondered if you could give me any advice how to manage that.
I will do my best. I'm a mere doctor. The best people are the lymphedema therapy team. So I would direct you to my colleagues at St George's or your local lymphedema therapy team. But I think there are tips and tricks that can be used to help. I believe, there's the lymphatic drainage massage techniques, and somebody could do that to you, or you could learn to do self-lymphatic drainage massage. You can sort of do that internally with a glove on and manipulate fluid in the cheeks. I think linking you in with a speech and language therapist to teach you specific swallowing techniques would be something that's proving helpful. And there was a presentation last year at the BLS about new techniques, new tools that are being used to help people that have significant tongue swelling and internal things. So yes, I would divert you to the experts in the clinic, but there are things that can be done to help. Thank you. Good question.
Thank you very much indeed. And it is on the e-books, isn't it, Head and Neck?
I believe so. Yeah.
Sadly. This is on behalf of one of our guests. It is reported that weight loss medications and injections have been explored as potential treatments for lymphedema, as they can help to reduce inflammation. What are your views on this?
I'm very excited about this question. I'm very excited about this topic. So in my clinic, we see an awful lot of patients struggling with lymphedema. And I'd say over the 20 years that I've been working in the clinic, I do feel that obesity has complicated the clinical picture for many of my patients. And we know that obesity is a risk factor for getting lymphedema. And we know that if you can lose weight, lymphatic function can improve. So any treatments, GLP-1 agonists, weight loss injections that can help someone struggling with their weight, I'm confident will improve their lymphedema. But what's also really interesting is that these drugs, whilst working on their weight issues, are also proving to be anti-inflammatory drugs. And we go back to Stan Roxon's drug trial with Bistatin, an anti-inflammatory drug. So these drugs, primarily given for weight loss, hopefully will target the inflammatory pathways and improve someone's lymphedema, not just through the weight pathways, but through the anti-inflammatory pathways. And I've had patients in the last few years contact me, those with primary and secondary lymphedema, and say that within a few weeks of starting treatment, so before they've even lost significant weight, they feel their lymphedema has improved and been easier to treat. So for me, it's incredibly exciting. And I really do hope that this proves to be something else that we can add to the toolkit to treat our patients. And I believe in America, they've got a trial up and running now, 110 patients with arm or leg lymphedema going to have treatment with the GLP-1 agonists, and they're collecting data on quality of life, limb volume reduction, and also cellulitis infection risk as well. I think that's going to be something exciting that this hopefully will improve for our patients. So yes, very, very exciting times. We just have to work out how to fund these drugs. Unfortunately, that's going to be the challenge for the NHS at least.
Thank you. Is one of the drugs called Manjaro?
Yeah, so Manjaro is the newer one. It's got another name, tirzepatide. The predecessor to that is Wegovy, semaglutide, Ozempic. But they're all these GLP-1 agonist medicines targeting those same pathways.
Next question is from Bobby.
Hello, I've had lymphedema since 1985. Do you have any advice on how to deal with hardened and fibrous tissue in the thigh?
It can be a challenge, can't it, when you've got long-standing lymphedema and all that fibrosis occurs. I think you have to break it down into the different aspects to target. You need to make sure that you've got access to a good moisturizer to rehydrate the skin and apply that regularly. You need to make sure that you've got access to good compression. Often lymphedema skin changes occur because the compression perhaps hasn't been aggressive enough in the early days. So if you're in good garments now, but there's still fibrosis, maybe it's a case of linking back in with the lymphedema therapy team, exploring if there's a need to have some intensive bandaging, so bandaging done several times a week, talking with them about, comfy wave or other garments to use at night, Velcro wraps. I can see you nodding, you've done all of this. Working with a therapist to see if there's any other gadgets that they found helpful. The science isn't perhaps so great behind all the gadgets and things, but it may be that they've got a trick up their sleeve they can use to help you. But we haven't got any medicines yet, I'm afraid, to fix the fibrosis. If it's a very big swollen leg because of fibrosis and fat, then liposuction is a way to remove that. It's one of the only NICE approved treatments for lymphedema, but it's not a cure, far from it. When the liposuction occurs to a big fat fibrotic limb, it's successful in removing the fat and fibrosis, but the downside is it can tear the lymph vessels that are still working in there. So you can end up with significant fluid swelling after the surgery that has to be managed with very aggressive compression. So whilst it sounds amazing to have liposuction, in reality, it's not an easy journey, but for some people it's the right choice. But if you want to have a chat afterwards, happy to try and explore that with you.
I think it's fair to say from the history of other golf days that I've done, there are a number of people either on this golf day or previous that have had surgery, be it liposuction or LVA. So if you're happy to have a quick show of hands, if you've had lymphedema surgery, be it lymph node transfer, LVA or liposuction, because those who haven't, if they want to ask any of those that have what it's like and what to expect a break, then these are the people with their hands up.
Matt, can I ask a question?
Of course.
Can I get those people to raise their hands again for me, please? Of the people with raised hands, keep them raised if you would do it again. Interesting. Yeah, the majority would. Okay, it's good for me to know because we're still learning in the physician's world as to how helpful surgery can be, and I think it's about patient selection. So it's good that the majority kept their hands up. Thank you.
Next question's from Keith. Just pass the. Thank you, Keith.
Hello, Professor Gordon.
Hello.
My name's Keith Currier. Due to time staff pressures at the Churchill Hospital clinics in Oxford, they no longer see patients who live outside the Oxford area. The Cynthia Spencer Hospice in Northamptonshire will only treat cancer-related lymphedema. Myself and other members of my family have neurologists, and we're now experiencing the post-COVID lottery where we can't get treatment. What can be done between the NHS and the local hospices to help bridge that gap?
I wish I knew the answer. I'm afraid this is a story that we're hearing more and more. So it really is a postcode lottery, isn't it, for people with lymphedema? It's almost easier to access lymphedema treatment if your lymphedema is cancer treatment related than if you have secondary lymphedema from other reasons or primary lymphedema. Again, the story that we hear time and time again that lymphedema is underfunded, under-resourced, there aren't enough staff to fill the clinics, let alone commissioners happy to invest in the lymphedema clinics. I think the key to this is to play the long game, which is to work on education of doctors, education of people in management, people with the money, and make them realise that people with lymphedema need to be cared for immediate reasons such as quality of life, but also for reasons of reducing the risk of cellulitis. And the cost of cellulitis to the NHS is huge. Millions of pounds a year spent on admissions, very expensive hospital admissions for treating cellulitis infections. So I think if we can get enough data and take it to the powers that be that have hold the purse strings and make them see reason that it's worth investing in lymphedema and that all patients should be able to access care close to home and good levels of care, then we can make a massive difference to the NHS, which is currently struggling financially. So I don't know how we fix it. It's difficult for one person standing up here to say, if we do this, it'll all work. But I think maybe if we work collectively and we educate and we target the ICBs, which are the new name for the people in the different regions that have the funding and the power decisions as to which clinics stay open and who they see, I think probably we can change things because we need to.
I think it's a fair point because more people are being correctly diagnosed with lymphedema, but there isn't the infrastructure necessarily the new blood comes through in all areas, and it has received we've seen a number of closures, a number of people that have tried to retire in the NHS have been encouraged to come back for a 2-day week just to keep the clinic open. So it is a challenge. The final question, thank you for answering that, is from Adrian before we come on to the next section.
Thank you, Matt. I'm usually last at everything. And I also get put at the back of the room on probably what's described as the naughty boys table. Yeah, Professor Gordon, delighted to be able to ask you a question directly. Matt, as always, managed to arrange the most brilliant speakers. Very interested to hear what you have to say. Now, last year, Matt and Vicky and I were lucky enough to go to St George's to have a look around at both the wet and the dry labs. And after that, we had a conversation with Pierre and Peter. And what emerged from that was an idea, an idea, that it would be a very, very good initiative and development to create a lymphedema awareness and research centre, probably based at St George's. Clearly, LYMRES is gaining a lot of momentum because of the great work done by Matt and Jenna and a few other people. And my question is, do you think that would be a very, very useful priority for some of the funds to create a dedicated centre which would hopefully attract the highest calibre researchers, brilliant young people to work in your team in order to accelerate the research towards the cure?
Thank you. Of course, my answer is biased and it's going to be yes. That's the short answer. The long answer is I do think that it makes sense to do this, to sort of focus on one or two areas within the UK to do the research. You need to consolidate the knowledge, consolidate the skills, but also build upon the skills that are already there. Whilst there are many lymphedema therapists doing research in their clinics, it's difficult for that to really gather momentum and yield enough data to make big changes on a national or international level. And I think if you've got a centre, for example, at St George's, where you've got people who've been working in the field of lymphatic research for the last 40 years, and our numbers are increasing considerably, it makes sense, I think, to invest in them. What's also special about St George's, City St George's and St George's Hospital is it's quite unique on an international level that, as you've mentioned, we've got the labs on site in the hospital. So it's fantastic that the patients are seen in the same building that the research actually happens. And what we make a policy of doing in our lymphedema research team is inviting the lab workers when they join the team to come down to clinic and meet the patients. And I hadn't appreciated that for people working in science, they don't get to see patients. It's not something that's offered elsewhere. And it's really powerful for the scientists to see the young people, the older people living with the diseases that they're working on. And it really does, give them more momentum, enthusiasm and passion to go to the lab and make discoveries, because they can see the impact that it has on real people. And I think also at St George's, being, the university is within the hospital, you've got a much quicker turnaround time for sort of bench to bedside, so the laboratory research bench to bedside care in the clinic, because it's this one big family working together. And I think also investing in one centre allows you to get more impact for each pound that you invest as fundraisers, because it's going to go further and it's going to achieve results for the patients quicker, I firmly believe. So yeah, please do invest if you can.
Thank you very much indeed for all your questions and for such comprehensive answers. Now we move on to the next stage, which asks you about LYMRES, lymphedema research, and how vital their research and their work is at St George's for helping future generations with lymphedema. So without PowerPoint, over to you.
Thank you. I mean, I think I've spoken a lot already about the research that we're doing, but if I break it down into the different topics that we do. So most other lymphedema research centres focus on one aspect of lymphedema research, and that might be the genetics of, but it would be people working in a lab without access to the patients to see who they're helping treat, or it would be looking at imaging techniques with ultrasound, MRI, or other aspects. At St George's, we're very lucky that Peter Mortimer has just been, to quote himself, such a huge lymphomaniac, and so, desperate to cure lymphedema that he's had fingers in so many pies over the last 30, 40 years, that we've expanded our research interests. So we now encompass many different aspects. So we look at the genetics of primary lymphedema. And as I said before, it's not just one disease, it's probably 200 different diseases. And we're learning so much about how to diagnose these children and young people, or even adults with primary lymphedema in our clinic. The St George's team have created a diagnostic algorithm we're on our third version, soon to be fourth version, I think, of how to look at someone in clinic and work out what type of primary lymphedema they might have, what genetic test we can do to see if we're right, and that genetic result, if you can get it, helps guide the family about risk to other children and future pregnancies for that person with primary lymphedema. It guides us on how to work out, are they at risk of any other health problems? Some types of primary lymphedema might be linked with heart things, or potentially some serious things that might increase the risk of cancer in the future. So it's important to make an accurate diagnosis so that we offer the best possible care to that patient. And this diagnostic algorithm that St George's is now quite famous for has been utilised now internationally to help other doctors and healthcare providers working in the field of lymphedema make better diagnoses and treatment plans for their patients. So that's one aspect of research, that through discovering the different genes and working out how it all fits together and creating a diagnostic algorithm for others to use, patients internationally are benefiting. We're making new gene discoveries. As I said, there's 41 genes on the diagnostic panel. So a patient comes to clinic, and if they've got lymphedema that's early onset, so in the first 2 decades of life, we'll probably offer them a blood test to look for a primary lymphedema gene mistake. But we do say we only find a mistake in about 14% of our patients. So we've got lots more genes yet to discover. And on that note, we have got a new gene for Milroy disease. I can't tell you the name now because it's still top secret and not yet published, but it's exciting that we are still making more and more discoveries that will eventually lead to targeted treatment. The team at St George's are working both in our patient group with these drug treatments I talked about before, the treatment for Noonan syndrome and the treatment for Klippel-Trenaunay syndrome with the drugs that we have, but we're also using that knowledge in the laboratory to try and see if medicines that are available for other things can actually improve any problems that we can see under the microscope in the lab. So that's exciting. We're also part of a drug trial, the first drug trial using a new medicine for Klippel-Trenaunay syndrome. So that's exciting as well, and that will yield better treatment for some patients. And then we can't forget our imaging studies that we do at St George's. So traditionally, all we can offer on the NHS to look at someone's lymph system is lymphoscintigraphy, where you have a little bit of radioactive tracer injected between your toes or your fingers, and it's quite painful. And it can give you a crude idea as to whether your lymph system is working properly or not. But it doesn't give you any anatomical detail. It doesn't guide treatment. So we now have research studies looking at the lymphatic system in more detail using both MRI techniques, looking at arms and legs, or more recently MRI techniques looking at the central lymph system, the thoracic duct and other pathways in the torso. And it's helping us manage our patients better. If we can see what's going on the inside in this see-through system, we can direct treatment, perhaps with the help of the interventional radiology team or the surgeons at times. And we've also got the Indocyanin green study, which is where a little bit of green dye is injected. And we can look at the lymph system in real time, pumping normally or abnormally. And we're trying to see how that differs between the different types of lymphedema in the hope of one day having better, different treatments. So I think we're moving towards a personalized system where one day the goal would be you come to clinic and you have a blood test to see, do you have a primary lymphedema? What's your gene mistake? Maybe there'll be some inflammatory test we can look at, which will guide anti-inflammatory treatments. You'll have your special imaging test to see what your lymph system is doing and how we can guide treatment. So I think it's all about personalised medicine in the future, and the research at St George's is definitely leading the way into achieving that.
So much, and of course, this all needs money. This all needs funding.
I'm afraid it does.
And tell us a little about the funding at the Lymphedema Research Fund and how that works with LYMRES.
Yeah, so thanks to everyone's donations, both from people in the room and from elsewhere. That research funding, it's just so important. So unfortunately, in recent years, money has dried up, not just for the NHS, but for research projects as well. The funding bodies, the large funding bodies, for example, the MRC, or the British Heart Foundation, they have less money in their pots. People aren't donating as much. There's been issues after Brexit with getting access to funds as well. So our money has dried up. And what many people don't realise is the majority of people working in research, they're funded by their grant. So you apply for a pot of money called a grant for a project, and that, if you're successful in winning that money, for your project, that will fund those 2-3 years you're working on that project. But when that project is finished and that grant has ended, nobody's going to keep paying your salary for the majority of the junior researchers. So that knowledge is then lost if those people go and apply elsewhere. So the fact that there's money coming in to support the research projects, in particular our imaging project, we had an excellent colleague who was looking at employment elsewhere because the grant money ran out, but the funds arranged through you guys helped support this colleague stay on for another year, do some fantastic research, which really is exciting and will change things in the future, but also help us then get more funding for a longer term plan for him. So it's so important that we have access to these pots of money. And it, the tiniest bit really does help. We're not talking hundreds of thousands of pounds here. £5,000 can help us extract DNA from a certain type of patient group that we're really interested in looking at. It all helps. So we're grateful for everything that we get. Thank you.
Thank you very much indeed. I'd just like to thank you once again for your time in coming all the way out. And ladies and gentlemen, please put your hands together for the wonderful Professor Kristiana Gordon.